Good afternoon. Today is March 23rd, 2023, Thursday. We are going to cover colorectal cancer screening. I have Dr. Sachin Vaid, who's a colorectal surgeon, who's joining me. Dr. Vaid, how are you doing?
Hey, Kemal. Good afternoon. How are you doing? I'm doing well. Thank you.
And we do these, as you know, almost every week. So we are used to having a little delays because we work with actual physicians, real physicians. So sometimes Dr. Erkan is running late because he's doing a case or patient needs something, and it's all okay for us to have those. Thank you for being with us. Now, this is our third session. Every year we do this in March together. And as now the 45 is the new 50, so from the colorectal cancer screening standpoint. So if you can actually give us the background of the disease itself, and we are going to kind of focus on the screening and the other treatment options, so then we can go from there.
Yeah, so the cancer of the colon rectum is, as you know, is the third commonest. I mean, depending on what you're looking at, it may be the second or the third commonest kind of cancer in the United States. It involves all age groups. It used to be in the past a disease of the 60s and 70s-year-old people. That's why we used to do colonoscopy at the age of 50 years, so that if you find a polyp, it takes about 7 to 10 years for a polyp to turn into cancer. So if you can kill that polyp in its tracks, it's not going to form cancer. And basically, you'll be preventing the progression of that. But over the last few years, we've seen younger and younger people are getting colon and rectal cancer. And we don't know what the real cause of that is. It could be multifactorial because of a sedentary lifestyle, us taking less fiber, more meat, using more artificial products, like margarine and things like that. We don't really know what the real cause is, but we know that things have changed from the 1980s, 90s, coming into 2000s, and younger people are getting it. That's why the 45 has become the new 50 for that reason, and screening has kind of come up to 45 for that reason.
So last year when we discussed this, I did not have my colonoscopy yet.
Yes.
So I was 48 last year, so then this year being 49. But it wasn't the screening that kind of I'm going to maybe just open up a little bit. So the issue of not getting this on time, because what happens is, I think many people, there is this still stigma of not sharing the information with their primary care physician. And I'll attest to that for my own. So, and then my blood work actually showed low hemoglobin. And then he was alert. He was actually kind of worried because he didn't know what was happening. So then that's when I had to come out to him and then say, well, so this is what's happening. Because there's always this embarrassment. Like, you don't want to share this with everyone. This is happening with other stuff, but this is always kind of like an issue of a joke, like the topic of a joke. People are kind of like, oh, you didn't get your colonoscopy. I'm sure you're going to get it next year. All this stuff. But then what I realized when I first find out the issue was happening, that wait time until I find out what if I had cancer. So after this COVID, because I was one of the first COVID people, after the COVID, that 10 to 20 days that I was going through, this was my second scariest time. Because the thing is, you told me last year that I should have got it last year, and as a screening, versus now it became like acute problem. Then it could have been so late. So if you can maybe educate us on this time that we are diagnosing this issue, how important this is. Like if 6 months versus 9 months versus 12 months, how much difference does this make in people's life? I think that would be really an eye-opening discussion.
Absolutely. So what do we call screening? We call screening meaning that you have no symptoms and you want to look at your organ to find pre-cancer stuff or early cancer stuff. And what's the advantage of doing that? Why is there a major push all around the world to get screening done? Screening mammography, screening for cervical cancer, screening for prostate cancer, similarly, breast cancer, screening for colon cancer. We want to find pre-cancer stuff or early cancer. Because when we do that, if we find pre-cancer stuff, we are basically done during colonoscopy for the most part. I mean, we remove your polyp, life is good. We don't have to do any surgical resections. We're not dealing with cancer, and we've stopped the progression of that polyp into turning into anything nasty. So that's why it's very, very important that we stick to our screening platform and we do it in a timely fashion. Because once it is now getting bigger, now you have a problem. Now that polyp has turned into cancer. Again, screening is still important because you're not having symptoms. You're still going to call it screening. But if I find an early cancer, still you are almost cured. If I find a stage 1 cancer, the survival rates are, you'll probably be showing in this slide, the survival rates are probably more than 95%. If you come into stage 2, we're talking about 5-year survival, which is close to 80 to 90%. So essentially, we are curing you of the disease when we find it in an early stage. Now, when do people start getting symptoms? People don't start getting symptoms early on with the cancer. They start getting symptoms later on in the stage. What are the symptoms? Abdominal pain. Okay, you have abdominal pain. What do you think is causing abdominal pain? The cancer in the lumen of the colon has gotten so big that it's giving you pain. Now, of course, by that time, it is not a stage 1 or stage 2 disease. It has kind of progressed. Again, bleeding, again, a marker of progression of disease. Weight loss, progression of disease. So those are the things you want to avoid. We don't want to get to a point that you're having symptoms and we are doing it for you. We want to do it early when you don't even have symptoms. So if we are fortunate, we find nothing, or we find pre-cancer small polyps, or if anything, we find early stage colon cancer rather than advanced stage. Also, one thing in mind, we say screening at the age of 45, but if anyone is having symptoms, which we just discussed, pain, bleeding, altered bowel habits, before 45, they need to have a colonoscopy done as well. It's not common. Over the last year, I would say I have done more people in their 30s with rectal cancer surgery than people in their 60s. If you look at my schedule, you'll see there are more people in their 30s and 40s who had surgery for cancer rather than people later on in their lives.
So, Dr. Vaid, so just to put it in perspective, 37-year-old who's having hemorrhoid bleeding time to time. The problem with this issue is there are over-the-counter medication available, and then we love treating our own issues without discussing the issue with the expert. So how do we separate how serious this issue is? Like someone who's really doing heavy weightlifting, even someone who's playing tennis every day, they can have these issues, right? So when do we take that seriously? I think that's maybe the main point.
That's it. You hit the nail on the head. Let me just tell you this. Every human being has hemorrhoids. These are the veins in your anal canal. If you are a human being, you will have those veins and you will have hemorrhoids, and they can intermittently bleed on you. But if they are bleeding, we can say, oh, is it from hemorrhoids or is it from something else? I would say if you are bleeding, get yourself evaluated. You have hemorrhoids, you can take Metamucil, you can kind of take more fiber in your diet, fluids, and see if it gets better. If it does not get better, it's lasting more than 2 to 4 weeks, I think you need to be seen by someone. Like I said, everyone has hemorrhoids. We can attribute all bleeding to hemorrhoidal bleeding, but bleeding which is ongoing, despite you having changed your dietary pattern, you are bleeding in the bowl, which is serious, or having any alteration of bowel habits with that, I think that warrants an investigation by the specialist. There was a patient of mine, actually, I did her last year. She was 29 when I met her for the first time. She's been having the same bleeding you're talking about for 6 months. And she came to me 6 months later. Now we have a problem. We had a big problem, but that problem was taken care of and she's doing good. Right.
Let's see. So that's, I think that maybe for those people who may think that this is just for people who are aging, that's not the case, because this can happen with any age. And then if it's not getting better in 2 to 4 weeks, they should definitely be seen. and they should not do what I did. Talk to your primary care physician, make sure that he's or she's able to direct you to a specialist if it's needed. But going back to the screening for people either over 45 or 50, once it's done, based on the screening results, based on the biopsy, if it's needed, so then they may need to repeat that. So can we just kind of go over those to see what needs to be repeated and how often you need to do that?
So in an average risk population, meaning they have no family history of colon cancer, they do not have any personal history of colon polyps, and they have no symptoms, the regular screening interval should be every 10 years. So every 10 years, we do the colonoscopy, unless there was some concern on the previous, meaning the prep was not clean or whatever. But if everything is good, regular screening interval for average risk population is 10 years. For someone who has a family history of colon cancer, now family history is defined by one first-degree relative or more than one second-degree relative, then you do every 5 years. And in that, in the category of family history, you don't start at the age of 45. You start actually 10 years before that, or 10 years before the time it happened in a family member. So for example, if someone was diagnosed at the age of 42, their family members need to start at the age of 32. Otherwise, if the screening is 45, they start at 35. So they should start like 10 years before that. So that's for the family history. If someone has had a adenomatous polyp, adenomatous polyps are pre-cancerous polyps. Those are the polyps we are interested in. Those are the polyps which take 7 to 10 years into turning into cancer for the most part. So if you have that, then the screening interval typically is every 3 to 5 years, unless the polyps are big, flat. It also depends on the morphology, like the size and the shape of the polyp. If the polyp is flat, if it's more aggressive, it's an adenomatous, but like more aggressive adenomatous, then, or you have multiple, or the size is big, then you come back in 1 to 2 years, sometimes even 6 months, depending on what cells you are looking at, like what came back in the pathology at the time.
I see. And then there are some cases where they have to repeat, is it every year or every 2 years, right?
So if you have a strong genetic component, meaning if you have some sort of a syndrome like a FAP, familial adenomatous polyposis syndrome, or HNPCC, which is a hereditary non-polyposis colorectal cancer, in those conditions, you have to repeat every year or every 1 to 2 years, depending on what your risk is and where the polyps were and things like that.
So I was actually just giving the background on colonoscopy a little bit from my personal experience, but there was a Cologuard also used as a screening, and there are some patients do like it and many patients don't. What's your experience with your patients? Like
Cologuard, I would not, for someone who is healthy and has average risks, I would not recommend Cologuard for those guys. Cologuard has both high false positive and false negative, meaning if Cologuard is positive, I cannot trust that there is polyp, like there's advanced polyp or cancer. And if Cologuard is negative, then also I cannot believe that test. So why do I do a test when I cannot believe it? That's number one. Number two, even if you look at the Cologuard's website, it says we capture advanced polyps and cancer. When we do colonoscopies, I do not want to capture advanced polyps and cancer. I want to capture early polyps or early stuff, which does not change into cancer or anything which requires surgery. So I want to stop this endoscopically rather than me having to do a surgical resection. So for all those reasons, I do not recommend Cologuard in people. Cologuard can be used as an intermediary thing, meaning if someone says, hey, you know what, come back in 10 years and 5 years, if you're worried, you can do a Cologuard, that may just let you get a colonoscopy sooner than that. Or if you're medically sick, meaning you are on oxygen, wheelchair bound and things like that, then maybe they may be enrolled for Cologuard. For otherwise healthy population, I do not think that's the right screening tool yet.
It's also kind of like overwhelming to do that at home.
Is that right? I don't know how to do it.
So that's what I was ordered first. So then the box was sitting there for several weeks, and then I returned it after that. So then it was a little bit late for colonoscopy, but I think I'm glad that I did it. One other thing is that
so every day you came back from work, you saw the box The box saw you, you saw the box. Both
we looked at each other for a long time in the study room. So after looking at each other for maybe 5 weeks almost, I'm like, well, I have to send you back.
Forget about it.
So, but the other thing is with the colonoscopy, some people, I think, having issues with the prep. Can we actually just go over that to explain what would be the best prep?
Yes.
Now, I have to do twice to prep. You know why? Did I tell you what happened?
No.
My first one, after the prep was done, I went there next day, and because you don't eat and you don't drink anything, so then I had a piece of gum in my mouth.
Oh.
And the receptionist said, we cannot do your case today. I'm like, how come? She said, because you're chewing gum. So it was already too late, so then I had to repeat the prep again a week later. But what's the best way to do the prep? Because if they don't prep well, then what you can do, what you can see is going to be limited. So, and then we don't want patients to go back and then do the prep again and then go back to the procedure again. So what's the best way to prep the patient?
So let's start off with that. We have multiple preps in the market. And in the past, we used to have preps which were high volume preps, meaning you had to take 3 to 4 liters, and they were severely dehydrating. And we used to do that for a long time up until we have these smaller preps with less volume, which have come up, and it's like a split prep kind of combination, meaning you take half the bottle at a certain time, and 6 hours later, you take the other half. So yes, so we have a variety of preps available in the market. They all work. And of course, their job is to purge you. That's why they are not pleasant. I would not be lying that any prep is pleasant. It's a purge. It's going to flush you out, and that's its job. So the newer preps, which I kind of like, are the split preps, which are smaller volumes. You take one bottle or one part of that preparation at a certain time, and then a few hours later, you take the remaining. That way, what I've seen is patients are cleaner and they are less dehydrated. Because one of the problems with the preparation is you get dehydrated because you get flushed out. And of course, you've not been eating and drinking the whole day before, and that kind of adds to that. So that's a portion of the preparation. In terms of what you should be eating, what you should not be eating. So you have a light breakfast, and after that, what I have been doing, and that's a typical recommendation, is you stick on a liquid diet. Mm-hmm. If you're a diabetic and you take your medications, you take your medication. And if you're thinking that your sugar levels are going down, I even tell people to add some sugar in their drink so that, one, it's pleasant, and second, they don't get hypoglycemic. You stay on your liquid diet throughout the day, and then you start your preparation. You can actually be drinking liquids up until 2 hours before your procedure time. And chewing gum is not a problem at all. I don't know why you were canceled because you were chewing gum, unless you were eating something along with chewing gum.
So the problem is I didn't go to American Surgery Center. So that's why patients should come to American Surgery Center. So I talked to our director of nursing, and then she said, well, we would just maybe make you, we will still do your case on that day, but maybe like 2 hours later.
Yes.
So, which would be fine. But because I do want to have our nurses to see me, like we all have this stigma. So that's the issue. That's why we are kind of discussing this in a funny maybe frame in a way that even for me, like I'm one of the owners of the surgery center, and then I just didn't want to be there. So you didn't do my colonoscopy, right? So the only reason is because there's that stigma. So there's because like if it was a diabetes issue, then I would come to you, right? So there's no, there's no reason to be shy. But if it comes to this, people are all like, it's a different issue. Well, it's not. It should be the same. And I'm saying this is the same, but I still have to go somewhere else.
No, absolutely. I agree. I mean, when you have a prostate problem, you will go to a urologist, and I would urge people to do that for the same reason, because, that's also an organ people don't want to talk about, but they have cancers. Yeah. So cancer, same story. Breast cancer, same story. So colon is a killer. Colon cancer can kill people. It kills people, kills a lot of people. More than killing people, it alters your lifestyle. Say you have something bad and now you need a colostomy for the rest of your life. Think how lifestyle changing that is. as opposed to getting colonoscopy in a timely fashion.
So now, do you think COVID had some impact on the overall
Absolutely.
issues?
Absolutely. So I've seen over the last, I would say, now things are settling down, but since last year, I think a lot of people did not get their screening colonoscopies on time, or even if they were having symptoms, they just never went to the doctor to kind of get it checked out. And people were coming more and more advanced stages. Mm-hmm. So people were coming only if they were having issues. So I have been doing a lot of advanced cancer operation, meaning in the past, we used to catch them early. But I would say they had the percentage of people coming with more problems has definitely gone up since this COVID, because I think there was a 2-year vacuum in which we never kind of took care of ourselves.
So there's this new study, people who had COVID in the beginning of the COVID pandemic had 56% more chance to have GI tract issues. They're more at risk. So then that comes into the colorectal at some point, right? So there's still some, like, other than delaying the care, not doing certain things, I think there's some correlation with COVID itself. And I think there's more to come from that study. But it's all interesting in so many ways. But I think one really simple thing for me is, I think for everyone is, screening saves lives. So if you do screening and if you do it on time, this is the best way to prevent some of these issues. At least get it diagnosed earlier, so then you can actually you can have a proper treatment and less painful treatment, and also you can live longer. So this is that simple. So from our accountable care organization, from United Medical, we work with our primary care and I make sure that patients are getting their colonoscopy orders. And even every once in a while, we still get some pushback from the patient that, why are we doing this? Why are we doing that? Well, that's because we want to save your lives, right? So that's simple. So screening is the key. And then hopefully everything is good, then you don't have to be screened again for 10 years. But if it's not, then you want to know that as early as possible, because it can get very scary. And then that's why we wanted to actually cover this issue in the month of colorectal cancer screening awareness. And hopefully people are there and listening, and then they can get their orders and then get it done on time. So Dr. Vaid, thank you for joining us.
One more thing I want to reiterate is that, which is very important, is that why do we think that colon cancer, I can allude to that earlier on in the talk, why do we think younger and younger people are getting cancers? Because we're eating more processed food, more sedentary lifestyle. So I think it's important for us to know that we all need to take about 30 to 40 grams of fiber a day, green leafy vegetables, fruits and vegetables, do our exercise, drink a lot of water, take red meat, but in moderation. It should not be red meat all day and then no fibers. Then if you do that, you'll end up with these kind of problems. And that's what we've seen. There was a big study which came out a few years back, just before the pandemic, from WHO, and they said more red meat, less fiber is associated with colon cancer. And I think they're right. That's what we've been seeing.
Oh, absolutely. So there's so many ways to prevent this. So then we want to make sure that people are getting the most education out there, and then they stop treating their own from Google. I mean, you can get information from Google. It's fine for education, but don't act on them, and then don't try to treat yourself, because the easiest one is one doctor visit, and then that will prevent a lot. So thank you again. So we'll be back with other events, and then I'm sure you're going to join us sometime soon. Until then, please stay safe. We'll see you soon. Bye-bye.
Thank you, guys. See ya.